Fixed partial denture, so FPD, also known as a bridge. Basically, to summarize that, it's if you had a tooth missing, this is a way in which we can replace a missing tooth. Right? So here's the glossary's definition of it. Also known as a bridge to your patients. Right? In our class, we'll call it an FPD, so you sound more like a dentist. Okay, so here's just some vocabulary or some terms you got to know. So the pontic, we'll start with that. A pontic is, you can think of it as the dummy tooth or an artificial tooth, right? It's the tooth that you're trying to replace. The retainer is the crown that goes onto the tooth, and it's connected to the pontic. And that connecting area we'll call the connector. The tooth that is used to support this bridge is what we call the abutment tooth. Okay. So pretty straightforward, just some definitions you gotta know. Pontic, abutments, retainer crown, connector, and you can throw a dentulous ridge there. Okay, so one of the guiding principles that we have as to, well, how long of a bridge is too long, right? Because at some point you gotta ask, okay, can I replace one tooth pretty easily? Probably. How about 2 teeth? How about 3 teeth? So if you have 3 pontics, is your 2 abutment teeth going to support a span that long? Right, so now we just get into some engineering principles is, you know, the longer the span is, then the more potential for flexure or maybe overloading of the teeth, right? So somebody came up with this idea, Ante's law. Actually, this guy named Ante. This was done probably in the 1900s, so before any kind of evidence-based dentistry was around. But he came up with this sort of conclusion. I'm going to kind of rephrase this definition. We'll simplify it. But basically, if you added up the root surface of the abutment teeth, he postulated that that surface area should be greater than the root surface of the area of the missing teeth, right? So one example, or let's just demonstrate, is if would a bridge from your canine to second molar be successful? Right, so we add up the surface area of the abutment teeth, so 14 plus 22 gives us 36, right? And then if we added up the surface area of the root structure for the pontic teeth, what do we get there? 45? Do that math right? Yeah. All right. So which number is larger? The surface area of the pontic teeth, right? So this would be in violation of Ante's law. So that's sort of how that works. And the thought was the surface area of the abutment teeth should be greater than the teeth that you're replacing. Okay. So here's a little chart to just give you average surface area of an average like central or lateral, so you can kind of get an idea of the difference between the teeth. So if you wanted to do some math and figure out Ante's law, you could. All right? We would say Ante's law is just sort of a guiding principle that we use, but there's not a lot of science behind it that proves that that's a good measure of whether a bridge will be successful or not. Because some people have actually done studies and they've taken existing FPDs, right, fixed partial dentures, that have been placed in somebody's mouth, or in patients' mouths. So here's a Scandinavian study. 60 fixed partial dentures were randomly selected, and then they looked at the function somewhere between 5 to 8 years after placement. And they did the math, and they found that only 5 out of the 60 fulfilled this Ante's law. And they followed these restorations over time. Right? So if you look at this chart, the way to read this chart is, so this is the surface area of the abutments divided by the surface area of the pontics, so these are the root surfaces. And if it fulfilled Anti's law, you would expect this number to be over 100%. So here we see only 5 of those FPDs fulfilled that Anti's law, and the rest of them didn't by varying degrees. Okay? So it turns out that only about 8% of these fixed partial dentures result in some sort of technical failure. So I guess the conclusion is that Anti's law, though it's a nice guideline, you can probably get away with a little bit more. Okay? All right, just a few other terms and things that you may see. So a traditional fixed partial denture has the pontic and then 2 abutment teeth that are connected by 2 connectors, right? Sometimes what you'll see is a single abutment tooth and a single pontic connected by just 1 connector. So we would call that a cantilevered pontic. So obviously this gives us the best scenario because you have a tooth on both sides of the opposing arch, and then the force that you apply to that tooth is going to be shared between the 2 roots. On the flip side, if you had a cantilevered pontic, well, it's only connected on one side, and then you have this force that is exhibited on the pontic that may have a higher incidence of dislodgement of this abutment tooth. So one of the few, we don't really advocate for this type of cantilever FPD. Sometimes you'll see this on implants. So if you had a single implant instead of tooth, and we're cantilevering a small tooth like a lateral, that may be appropriate. But the idea is that sometimes you don't want to touch the neighboring tooth. For example, what if this crown has already been root canaled and a crown and there's not a lot of tooth structure remaining on it? Well, one may be hesitant to take off this crown and then subject it to more force. So a compromise may be just hanging off a tooth off of the canine, right? So there's different clinical situations where a cantilever may be appropriate, but in general, I would say we're doing much, much less of these type of restorations, partly because we have a better, or we have other solutions for replacing a missing tooth, including a dental implant, which has kind of revolutionized or changed the way we treat implant in a lot of these cases, okay? But just for definition, so you know what a cantilever is. So long-term prognosis is poor. Forces are best supported when directed along the long axis of the tooth, okay? So generally, these aren't treatment planned at ASDO. So this was a study that just compared success and failure rates of teeth that were supporting a fixed partial denture or a removable partial denture. So you can see that they categorized, so they took about 1,200 teeth that were endodontically treated, and they had 4 categories, either no crown, just a tooth by itself, a single crown, or they use it as an abutment tooth. And just to refresh your memory, I think we have, let's see, there's a little slide on it, yes. In RPD, so one of the reasons why a tooth may need a crown is to change the contours of the tooth. And that's this situation here where you want a tooth to support a partial denture, and then the clasp of the denture is going to hug the tooth in a certain way to prevent this prosthesis from just falling down. So the idea is that if you didn't have this clasp here, gravity would just pull this denture downward and away from the tissue. Okay? So you want to customize the shape or the contour of this crown so that that clasp arm kind of hugs that tooth. Right? So you're going to learn a lot more about this in a couple weeks when you guys start your removable partial denture course. Right. So just wanted to give you an idea of the success rate for these teeth as you ask it to support more and more teeth. So a fixed partial denture, instead of the crown just supporting itself, it now has to take on some of the load of that pontic space. And then same idea with partial denture. Instead of that crown just supporting itself, it's now going to take on the load of the denture teeth that are added onto it. Okay? So we can see that the success rate as you ask it to take on more and more load drops pretty significantly over time, or as you put more load. So a crown, they would say it would only fail about 5% of the time. Once you subject it to asking it to support a pontic, it about doubles in terms of its failure rate. And by the time you ask it to support multiple teeth in an RPD situation, then that jumps to 22%. Okay? So a pretty straightforward principle. The more that you ask a crown to do or a tooth to do, the more likely it's going to fail. Okay? So that just helps you put some numbers to these situations so you can kind of categorize it in your head. Because these are kind of little tidbits that you can share with your patients as you help treatment plan and explain treatment to them, right? You can say, oh, since we're using that tooth as a bridge, to support a bridge, it's going to be twice as likely to have problems as if we didn't. So maybe that's why an implant would be beneficial, so we don't have to ask your neighboring teeth to take on the load. All right, and then the second part of that study talks about posts, whether a post was helpful or not. Okay. So in this particular study, they actually saw more failures or a decreased success rate when there was a post inserted. Okay. So yeah, just a few things to know about those studies. Go ahead and read them before their quiz on Monday. Right? So let's talk about a fixed partial denture and the order of preparation. So the concept is you're going to prep both teeth like a crown, and then you're going to make, you know, a provisional that just connects the two together. So the question is, so we're going to start with teeth number 18 to 20 today, with 19 being the pontic. So the question is, which should you prepare first, the molar or the premolar? Okay? Because you got to get both teeth to have the same path of withdrawal. So remember we talked about not having undercuts on single tooth preparations, right? What's the reason for not having undercuts? What problems would you run into if you had an undercut? So no path of withdrawal would lead to your wax step not being able to be removed. The same thing would occur when you try to make a provisional. It would get locked into those undercuts. So instead of just having one tooth to worry about, you now have to look at them together as well. So each individual abutment needs to draw on its own, but now also you got to look at the two path of insertions or withdrawals of both teeth, and then they too need to follow the same path of withdrawal. Okay? So these abutment teeth tend to be more tapered than what you may be accustomed doing, just for the sake of getting both teeth in the same path. So the question is, which tooth would you want to start with first? And the answer to that is you rather start prepping the smaller tooth first, because if you need to overcorrect the path of withdrawal on the other tooth, you got more tooth structure to play with. Okay? So let's say your premolar, when you first started prepping that, went a little bit awry. Well, you can go to your molar and then really exaggerate the amount of reduction there and still get it to draw, and you'll be further away from the pulp, right? You just have a larger tooth in which to make those corrections, okay? So the small tooth should be prepared first, because if there's an error that is made in the path of insertion, it can be compensated by over-prepping the second tooth. You'd rather over-prepare a larger tooth than a smaller tooth. The other thing to think about too is, and I didn't put a slide in this, but I probably should have, is think about the path of, or the orientation of the teeth as you move from the posterior to the anterior. What do we know about how the teeth are oriented against each other? It goes from vertical to slightly angled, right? So let's say your fixed partial denture starts to wrap around the corner, and let's say it goes to the canine or maybe the central, and you're going to wrap around from the posterior to the anterior. Well, you may need to over-prep one of the teeth so you get those teeth to have draw. Whereas if you had two posterior teeth, those are a little bit more straightforward because both are oriented just straight vertically, right? So if you think about the long axis of teeth, 18 and 20 are pretty much just straight up and down. But let's say you're doing canine from, let's say you're going from 11 to 13. Well, the canine starts to tip a little bit, okay? So the long axis of the canine isn't exactly straight vertical, right? So just something to keep in mind as you prep these teeth. Okay, so path of withdrawal. So let's go over this concept again with some visuals here, right? So you have two abutment teeth, and we simplified the geometry. So we have some taper. So both of the teeth individually have draw, plus they both have draw in relation to each other, right? So if you were to draw some lines here, we would see that we have no undercuts present. So if we did a wax up, or if we try to see or make a provisional, we would know that these have draw. So what if one of your abutment teeth was prepped so that it has an undercut? Now, if you draw your lines, you would see the presence of an undercut there. So this prosthesis would not draw. Right, so we're just basically expanding on that same concept of path of insertion, path of draw, whatever, undercuts. You're just now applying it to more structures. So there's more walls to look at. So you would know that something like this wouldn't be able to be seated. Okay, it gets stuck there. Or if you had something made, it wouldn't be able to be withdrawn. Our teeth are spread out much further apart, right? So you can't see both teeth at the same time with your small mouth mirror. So one thing that we'll have for you is a large mirror so that you can examine the teeth from different directions. Now you can see both abutment teeth at the same time to evaluate your path of withdrawal. Okay? Another little tool that we have for you, and we're doing this a lot more in the clinic now too, is wheeling out our little CEREC machine. Now we can scan the teeth. And remember, after you draw your margin, does everybody remember what step is next after drawing your margin? There's that path of insertion tool, right? And then you know if you have an undercut, what happens to that area that's undercut? You would see a little bit of yellow, okay? So what we're doing now is we would have you guys scan the preps when you think you got your path of withdrawal correct, and we'll go to that path of insertion step and then see if there's any yellow, okay? So that's something we're going to have you guys do in the sim clinic here, is after you're done prepping and you think you got it where you need it, okay? And do this before you show your row instructor, just so you can kind of think critically on your own, is use that CEREC as an aid to see if you got that path of insertion between both teeth correct. Because if you can't find a path that doesn't have any yellow, you know you got more adjusting to do, and you got to taper one of the walls a little bit more.